to start?
Whenever you are.
Well, good afternoon. It's nice to see you doing the social distancing as we have talked about for some time. I'm glad you're taking it seriously, and thank you for doing that. Let me give you a few updates today on the COVID-19. Let's start with the number of cases that we're currently seeing in the state of Kansas. We have 126 positive test results and cases in the state of Kansas. That's up 28 from yesterday. So as we predicted, there would be an increase in the rate of growth in the number of cases, and it's certainly in keeping with what we've been talking about, unfortunately. That's 4.4 per thousand, which is not near as high as many states, New York and Washington, for example, more in keeping with kind of the middle of the pack, if you will, in a per capita number of cases at 4.4 per thousand. Of those cases, 126, there's distributed around a fair number of counties now. We had 48 tested positive at the Kansas Health and Environment Labs and 78 tested positive at commercial labs, which overall we think of that as a good thing in the sense that, as you know from our prior conversations, we've had a lot of constraint on our state lab, and it's good to see that the other commercial labs are there to pick up the additional testing. So while of course we would rather see the number of cases dropping, I don't expect to see that anytime soon, and it's good to have the backup laboratory capabilities brought to us by the commercial labs. It's also interesting that, and we're going to talk a little bit more about testing, that about 4.5% of the tests that we run are positive. And that, keep in mind, here at the state lab, that's in ill people. So we don't test well people. We've been down this road before. That's in ill people. And one of the things we're going to talk about as we expand and get more testing capability, whether it's on the commercial side or on the state side, we're going to want to do more population studies to see what the prevalence is out there. I'm certain that it'll be much less than 4.5% of the tests that we do, because they will be in people that are not symptomatic, and as well as people who are ill or mildly ill. A little bit about the Kansas projections. We hit are starting to hit the numbers now. Once you get past 50 to 100 and above, then you get a little bit more ability to predict what the future will look like. The expectation for the state of Kansas, as really everywhere that's experiencing this disease, is that it'll double, and it's forecasted to double in about every 3 to 4 days. So by the end of the month, we had originally forecast that it would be around 300 to 400 cases. And I anticipate by the 31st of this month, that's approximately where we'll be. Probably closer to the 400 side. And you'll recall a graph in your mind's eye. I've compared it before to the Nike swoosh, where you're down at the low end and then it takes off on a fairly steep increase in the slope of the curve. We're starting up rather on the up side, unfortunately, of the Nike swoosh. Our goal by the stay-at-home and shelter-in-place is to top that number out, level it off, and then to drop it down, which is where we hope to get to sooner rather than later. And I would not expect to see immediate results from the increase staying at home, sheltering in place, et cetera, because of a couple things. One, there are so many exceptions to the stay-at-home, shelter-in-place approaches, whether they're ordered to be such or are voluntarily doing so in many of the counties, obviously, because I think unfortunately people are looking at this stay-at-home orders as, okay, what are the exceptions and how can I wiggle around them so that I can justify going outside and doing my stuff? And that is exactly the wrong approach. Whether it's a stay-at-home that's ordered with all these exceptions in place, or the advice we've been given all along, stay at home, shelter in place, you can do it voluntarily. We're grown-ups, we have the ability to make decisions, we have the ability to do this. It's not a game of avoiding the exceptions to justify going out in the community. So whether there's an order in place in your community, in your county or not, stay at home, shelter in place, and then if you must go out for the essential tasks, observe those social distancing rules, if you will, that are proven through epidemiology and other kinds of scientific approaches. These aren't just made up. They're proven to be effective. So observe these the few times you have to be out and about. A couple of things about testing. As you know, we have not had enough test materials all along the way here, but we have not tried to be a roadblock to getting testing. But all along, we use the testing materials and we get replenished, and sometimes we're down to just the gnat's eyebrow in terms of a day or two of reserve before we run out. So we have to be very careful about how we use our tests. When somebody comes into a hospital, though, we've used fever as a criteria, for example, and I think we're going to find that criteria is a very good one, but there are people that get ill from this coronavirus and don't have fever. I'm sure that we will relax that, and actually have relaxed that already. For example, a person, if they're sick enough to be hospitalized, already qualifies for testing in our laboratory. But my emphasis is, because we have such a scant amount of testing kits available, there is a lot of commercial capacity. So if somebody's in the hospital in afebrile, even by kind of rules that were like a few days ago, because this has been such a fluid situation, as you know, they can always get tested by a commercial lab. That's always an option that's out there. So nobody, caregivers, physicians in their clinics, et cetera, should not be reluctant to use a commercial lab. It's just that we can't burn through all of our testing materials. We just can't allow that happen. And the reason is because, as you know, we've run short. It's dictated by our testing criteria, and the receipt of the test materials is dictated by the federal government. That is where we get our stuff from. And it's been in short supply. So what we really have to, and I think these will make sense to you, short supply has caused us to look at it. One, we want to make sure that our healthcare workers and first responders are a priority population. That just makes sense. Those are the people that are really on the front line of this. Second is a potential clusters of unknown respiratory illness. In other words, if a person here has the illness, we want to know if the people around them have the illness as well, because that's where community spread originates, is from a person and then a cluster, and then it goes community-wide. So clusters. Hospitalized patients with no alternative diagnosis. In other words, they've gone through the other influenza and other respiratory diagnostic tests. Individuals over age 60 who have symptoms of COVID-19, who reside in nursing home, long-term care facilities, and other congregate settings. Those places, nursing homes, long-term care, congregate settings, like kind of halfway houses and adult daycares and those kind of things, that is an ideal place to have a cluster start and spread from there. So that's why it's a priority, and a very vulnerable population. Right now, if we have the ability to do about 900 samples is our capacity right now, and we're going through 150, 200 samples a day at the current rate. Protective equipment remains a hot topic. We get requests all the time. Right now, we have 25 pages of requests from different counties and healthcare organizations, large and small. And we're typically not able to replenish all of what is asked for. We've been pretty good. Last week, for example, I mentioned on one day we had, I think, 12 different counties that we replenished a good deal of the materials that were asked for. The next day, there was 20 or 30 different healthcare organizations, for example, that we helped replenish. This comes in semi-trucks from FEMA, and we get, just yesterday we got 2 semis full of the material. So we get moments of encouragement, which is good when things come in. The governor and General Taffanelli and I were on the call with FEMA last week on Sunday night, and to try to push. And the reason is that even Kansas is a fairly low populated state, and when we put out there our numbers, in this case today 126, that, when you look at it from a national perspective, that's a fairly small number to this moment in time compared to New York or Illinois or California. And true, compared to New York on a per capita basis, we are much lower. But compared to a California basis, we are right at the same place that California is, at about 4.4 per thousand. So My point of bringing that up is that we want to argue that we have full right to the same amount of PPE per capita that even the larger, more populated states get. Hope that makes sense to you. A couple things. KDHE staff is working around the clock, particularly our laboratory and our epidemiology folks. Our epidemiology folks are the ones that track the disease and do the detective work, if you will. This week we're starting to give people 1 day off. They've been working around the clock for the last 2 weeks, and I wanted to give a shout out to the excellent staff out at the laboratory and in our epidemiology section. And really, I could go on and on. There's up and down the organization. The phone bank has been upgraded. You recall that we had 50 calls a day 10 days ago. The last time I heard, I think we were over 1,300 calls a day. We have a new system that will allow a higher volume to come in with some nice features, some chat things, some materials to be pushed out to the people who are answering the phones so they can give the best quality information. We have 132 of our KDHE staff volunteering to man the phone banks. So again, a shout out to people who are giving their all. Even our Medicaid director, Mr. Adam Prophet, is volunteering time on his free time, which he does not have, to come in and do it. And it shows the spirit of volunteerism that we have in this agency. Website continues to be updated multiple times daily. And we talked about it, kdhe.ks.gov. It'll have a little different look. It's always adding new features and some stuff that you'll find to be very cool. We're working hard to keep you healthy and informed. A couple tidbits. One, mask reuse. We've been short on masks, and we're working with various care providers and OSHA and others to acquire ultraviolet light sterilization devices so that they can be reused, probably up to 5 times. We use ultraviolet light now to sterilize rooms after patients are discharged. And a mask can probably be used 5 or 6 times safely and still have the positive features. Obviously, they don't go from one person to a different person. They're labeled for your use, for that one person's use 5 or 6 times. Think of it as a tanning bed that you can put stuff into and sterilize it. There's a rumor out there that I want to address, and that is, and it's emanated out of Europe mostly, that ibuprofen and the other non-steroidal anti-inflammatories like naproxen and aspirin, those that are somehow harmful in COVID-19 patients versus acetaminophen, which is not thought to be harmful in COVID-19 patients. And the argument was based on a few anecdotal findings by people taking care of patients that said that there's a higher death rate, and I won't go into all the physiology of worsening lung symptoms in COVID-19 patients. Just on the 23rd, so just 2 days ago, the FDA came out with a very strong statement that says there's no reason to suspect ibuprofen or these other non-steroidals in causing worsening lung function. So we can take that one off the table. I think the World Health Organization a day earlier had said the same thing. Bed planning, one of the things that we're still in the process of, we've got a really good team working on how many hospital beds do we have, how many ICU beds, how many ventilators, et cetera, do we really need? Because now that our forecasting is getting clearer, I feel confident that we're going to be able to overlay what is going to be our bed and supply and staffing needs with what are the projections. Because you've seen in that flattening the curve thing that there's a line that when you exceed it with the number of cases, then that means that you've exceeded the hospital bed capacity. And we'll know that, I think, by the end of the week, hopefully, at least a high-level view of that. And the reason is because we're looking and working with the Army Corps of Engineers. Are there other facilities that we could reconfigure into what we refer to as alternative care sites? We've talked to the VA. You know, there's 3 VA hospitals here. Is there a way that we could nest all the VA hospital patients in one hospital and free up 2 hospitals? And I can tell you this as an Army medical officer, as much as it seems like, oh, we'll call in the National Guard and set up tents, mash tents, and pull up some ground ambulances full of stuff, that's hard. We would much rather move into a built environment that was built for patient care, that has gases and all the safety features in there. So that'll be more on that later. Not later today, but later in the week. Finally, the future. As it relates to the lab, there's some faster tests that are being developed, PCR tests, rapid turnaround, 45 minutes. We're going to acquire those because we think that one of the throughput is a big deal. And there's another testing methodology that does the DNA extraction, where we think that could, it's not available yet, or we'd have it in our lab, up to 10,000 cases, tests per month, which would be a spectacular increase in our capacity. Hospitals are developing the capacity to do these tests on their own facility. That would unencumber us a lot. And finally, a work in progress is we would like to develop satellite locations where samples could be drawn. Because it really gets down to the issue of why do we need to do samples? And we want to do samples if people are ill, so we know what they're ill from. That's kind of obvious. But at some point in time, we want to do a prevalence study. How much disease is out there? Matter of fact, in an ideal world, we'd be doing that right now if we had the testing capabilities. I'd like to know if somebody's asymptomatic and infected and spreading the virus. Because one of the questions I think is going to be really important is, what is the prevalence in the community? Because someday, a month from now, we're going to say, okay, the cases are where they are, whether it's going up still, level, coming down. When do we relax restrictions? When do we start to feel confident? When are we going to be comfortable to return more toward normalcy? And the only way we're going to really get there is by doing prevalence studies in the community. And that's why we really want to have increasing capability. To that end, I'm working with colleagues to develop satellite testing locations so that people can show up and get their samples drawn in higher volume to measure the prevalence. And they're in the places where you'd expect the KCK and Lawrence and Wichita, here in Topeka, Salina, Hayes. We want to have a presence throughout, but especially in the areas that's high population area. We need to find out more about the prevalence in the community. So finally, my closing comments, I guess, are we really need to take home isolation seriously, whether or not there's a declaration in place. Adults should not require declarations in place in order to follow great advice. So we need to follow great advice of staying home and going out only if need be, not looking. This is not a game, it's not a puzzle to try to figure out how to skirt around the exemptions that are in place. Creativity. I like when I see things about businesses that are allowing the ordering online and paying for online and then delivery at the curbside, for example. Best Buy is doing that, I understand. Great idea. That's the end of my prepared comments. Questions?
So, Mr. Secretary, are you satisfied with the county-by-county approach to these declarations? Seem to be targeting the populated counties.
Yes, I am. It feels a little awkward in some regards to have slightly different things. We've had to crosswalk what it means to different counties. And I think in an ideal world, people would just heed the public health messaging to do this. I guess some people have to have rules, and it helps some people, I guess, to organize their behaviors around the rules. I think it's, when there's so many exceptions, though, there's so many angles. I mean, taking dogs for a walk and visiting a shut-in, I mean, anybody can do that.
Obviously, President Trump has thrown out the possibility of maybe going back to normal around Easter. Do you think that's possible, and do you think we should be setting a date like that?
I think that's unlikely.
Most Kansas counties don't have any ICU beds if they have a hospital at all. Can you help us understand how problematic that is?
Yeah, this would need to be a regional approach, because the people that are sick enough to be hospitalized, they're going to go down. They can get turned sour very quickly. So they should be regionalized to a center that has intensive care.
And you have a task force, I want to make sure I understand correctly, you have a task force in charge of looking at, worst case scenarios, triaging, right? Like you described the situation with what if we have to rearrange the 3 hospitals in Topeka.
Right.
So are you looking at kind of, like the Harvard projections indicate that even honestly in the more moderate scenarios, the Topeka region, Wichita, Kansas City will be over capacity for the beds. I'm guessing that you guys are looking at all of that data and I mean, in a way, like they're saying, these aren't even worst case scenarios. These are moderate scenarios.
Yeah, yes, the answer to your question is yes. And then there's even things that we have not had to think of before, using CPAP machines for ventilating patients. I've not even considered that. I'm not a pulmonary and critical care doctor, but I've inquired with those folks, and that they can be reconfigured for that purpose. Or ventilators can be configured for more than one patient to ventilate them, and those things are part of that equation that's being looked at. Again, the purpose of, and that's one of the critical reasons for this stay at home, to reduce the amount. It may not reduce the total amount of disease, but it gets exactly what you're asking, which is it pushes down the curve and it pushes the cases into the future. And see, anything we can push in the future is to our benefit, because the presumption is we will have a vaccine and antiviral medications in the future. So the purpose really is to avoid a big spike now that overtaxes the hospital systems, for example, but push it out in the future.
Dr. Norman,
Yes.
KU Med was talking about having 8 or so patients in their hospital today, but they were awaiting tests on 40-something. So do we have any idea how many people are hospitalized at the moment?
4 in the state. There's
are hospitalized
with positives.
With positives.
Yeah.
And then there would be a larger cluster who are hospitalized awaiting results.
Yes.
Any idea how big that number is?
I know it every day. Matter of fact, Tim, I have it in my phone. I can pull it up every single day, but I don't have my phone with me. But we do know the number of those. And the interesting thing, and I think this is an important clinical point that you bring up, is that if they're positive or negative, it almost doesn't matter for the care they're receiving, but it really matters for how the staff taking care of them. But if they're in the hospital and critically ill or ill enough to be in the hospital with respiratory illness, whether it's diagnosed or undiagnosed, people are going to be in PPE. So it's one thing to say I'm living with the ambiguity of not knowing for another 24, and I hate waiting for test results. There's nobody that, I've made a career of hating waiting for test results. I can't tell you how important it is for peace of mind and for ironing out the approach. It's critically important. And we really want to help them with that, because it's an awful use of bed space. Although patients are very seldom kept in the hospital because they're waiting for the test result. The reason is that it helps to guide how we care for people.
So that's 4 of the 126 confirmed cases.
Yeah.
How would you
That was
describe-
yesterday's number.
Sure. If someone is in the hospital like that, are they critical, near death? I mean, or does it vary from the 4 cases?
It can be variable. I didn't mention, we've had a 3rd death in the state of Kansas, and I think that was yesterday, I believe, of a patient who had been hospitalized and then had been discharged to home and then was rehospitalized and died. I should have mentioned that at the top. And we're looking into, with the hospital and the people that cared for this patient, to see that's a little bit different course. Usually when people are hospitalized, and again, these are sick people typically before they even become sick with coronavirus. A lot, and this particular one had really bad emphysema, COPD. What was your original question?
Just how are the...
Oh, they can be everything from minor illness, but ill enough to be in a hospital, and it's usually around supplemental oxygen. By the time somebody needs supplemental oxygen, and if they're not normally on oxygen, you say, you better come in the hospital where you can, because you don't know the trajectory of their illness. Are they going to get bad fast? Are they going to level off or get better quickly? And curiously, this has been an interesting organism, this coronavirus. It affects people's hearts. And we've seen people with cardiac problems that are, because they come in with thought to be primarily a cardiac disease. You take their temperature and find to be febrile, and so you say, oops, better look at that. And or there's some people with gastrointestinal disease, diarrhea, abdominal pain. And that's a little unusual for respiratory illnesses. So we're getting more and more, and when I say we, I mean the world community is getting more and more experience. I talked about the various lines of effort last time, and one of the things that we've done is to have somebody that is, and a group of people actually that are doing best practices research worldwide to find out what is it that we can glean, because the literature is just starting to catch up now with what's been going on now since January.
That person obviously would be quarantined after they got
Yes.
out.
Yeah, we require them to be test negative twice before we kind of give them the good housekeeping seal of approval.
Mr. Secretary, I've heard a Topeka hospital official, Kansas City hospital official, talk about the immense cost facing these medical facilities that are shutting down their regular operations
Yes.
and healthcare and preparing for kind of a wave. So today, one of them raised the prospect of Medicaid expansion in Kansas. It's been a hotly debated subject, but long-term, perhaps it would cover indigent care for individuals who might, as this goes on, need help. So what do you think about that?
Oh, I've never gotten off that soapbox. Anytime I have an opportunity, I really continue to push for that, because you're right. And just face it, and I do know a bit about hospital economics, is that the elective cases, the hip replacements and valve replacements and those kind of things, gallbladder removals and some things if they're not too urgent, those are the ones that make a hospital's bottom line. And essentially everything else, acute care medicine, they lose lots of money on that, just to be honest. And and indigent care doesn't go away because coronavirus here. Those folks are still coming in the hospital. We'll take care of them. And it's a fascinating question you bring up, Tim. The world has not stopped when it comes to other things. Like, for example, next week I'm going to be doing some work around immunizations, because we can't blink on immunizations. We have some issues with on the environment side with water and air, for example. And we're still working those other things. It's not like we have the luxury of just saying, let's just take a pause and come back to that in the fall when things are tidier. So it is a real challenge to keep everything moving that direction. But there's no question, Medicaid expansion, it would put a strain, of course, on our healthcare finance people, because it would mean building a whole new line of business, essentially, with a $1 billion expansion. But we're up for it. Healthcare finance can handle that. They're doing the work now, and it would help out hospitals.
I wonder if I could ask you to elaborate a little more at all on how the task force is preparing. And I know that, they're kind of preparing for the scenarios that we're trying to avoid, but, so if we do run out of ventilators, we do run out of masks. Well, you mentioned, we'll try to reuse masks. We do need more bed space. Just help us understand how the task force step by step is looking at these scenarios too.
Well, the first thing is seeing what we really have by way of capacity now. And as much as and by the way, we consider the Kansas City metro, including Missouri side as well, because we're all in this together. And the coronavirus doesn't respect the state line. And KU gets a lot of Missouri patients. St. Luke's, I'm sure, at the Plaza gets Kansas patients. So it's a matter of working collaboratively all the way up to St. Joe and the area. It really is, one, what is the capacity that we now have? Two, what is the capacity that we could build and add to? What are the most likely scenarios? What is the worst case scenario? And then finally, how do we backfill for the deficits? And then a lot of that's about pushing on staffing and supply chain. And we've already put in, for example, for 100 ventilators from the Strategic National Stockpile. I don't know if we'll need them or not. We won't know this until, one, we get the results of our analysis done, and secondly, when we get into the thick of it, what mix of people end up needing ventilators versus critical care or non-critical care service short of ventilator use. But we've already put in anticipation of that to get our share, quote unquote, of the ventilators for Kansas.
The state has, right? Because I
Yeah.
know some hospitals are trying to order more as well.
Hospitals are, and we are as well. And some of those only can come through federal channels, and that's what we're trying to access. And to be honest with you, we find ourselves in sort of competing with other states, and And one of the things that we want to do and are doing is to justify the, why are we making the requests we're doing. I have a hunch that if New York had its druthers, it would take every ventilator in this, and I'm not holding anything against New York, they've got a big problem there. But I have a hunch that they would say, let me have every ventilator that's in the strategic national stockpile, and then when things calm down here, we'll pass them back out to you guys. We just can't count on that, and so that's why we're anticipating that we may need them and ordering them now.
Do you have specific numbers of, I don't need specific numbers, but when we reach a certain point, you could maybe move to hospitals, or you could start doing tests at hospitals?
That's exactly what we're doing. That's the analysis we're doing now. I don't have the answers for you today, but that's what we'll be. I kind of hope to have those numbers kind of roughed out by, and not just numbers, but an approach. Because it's a big difference whether you have a Corps of Engineers rebuild a Motel 6, or do you move into an existing hospital. Big difference.
Do you have any idea what time frame that could be? Is it in the next couple of weeks?
Yeah, I hope so.
Things
Yeah.
like that could be happening, or you would have?
Oh, we would have the ability to forecast what's going to be necessary. Last question.
Doctor, yes, sir. Celia's follow-up to Celia's question. You mentioned the thick of it. I'm sure people would very much like to know when that's going to drop, when that's going to be. Can you just take a stab at it?
If I was able to answer that, I probably would have parlayed a lot of money in the stock market and been retired long ago. But no, I'm taking it seriously, Tim. It all depends on if it's a seasonal bug or not. Okay. And we don't know that. If it peaks out in the springtime and then drops down, it'll probably peak out again sometime November, maybe as late as February of 21. I have a hunch, and I hate to say it that way. Let me rephrase that. I think there's epidemiologic evidence to suggest that it'll peak out and come back down, but then it's not gone, and it'll come back in as a wintertime organism again. I think the best we would suggest, if that's the case, would peak out in February of 21. Otherwise, I think that in the short term, if it's a seasonal, it'll peak in a month.
Would we need to hunker down that whole time?
Until we suggest not to, yeah. And that's where we are right now, which is, that's why I wanted the surveillance and the prevalence testing, is to find out when can we stand down. That's a big one.
Any update on the Wyandotte nursing home where the first death?
There was no additional positive tests from that nursing home. Thank you all very much.
Thank you.
Okay. And thanks for rolling with the punches in terms of this distancing and yeah, I appreciate that a lot. I think it's important we demonstrate these kinds of behaviors as well. Thanks.
Yeah, we'll hear about it.
You don't want to have I went from the governor's news conference about limiting the capacity of meetings to the House Republican Congress, which I counted 95 people. So they had not gotten the word yet.
Well, they got the word.